Good. Well, I think we'll make a start. It's great pleasure to have you, Julie, at the Maudsley Philosophy Group. We recently met in Copenhagen, which I enjoyed very much. And for those who don't know, Julie Nordgaard is a clinical professor of psychiatry at the University of Copenhagen. Real interests in psychopathology and phenomenology, particularly self-disorders and schizophrenia. And Julie is president of the European Association of Phenomenology and Psychopathology and Psychotherapy, and is going to talk to us about the phenomenological diagnostic interview. In fact, Julie, I know you've written a book on this, on the psychiatric interview. So we're super interested in what you've got to say. It's going to be the usual approach we take. So you'll speak for about 45 minutes thereabouts, and then we'll have some time for questions, discussion. So what I'll ask people to do is to keep their microphones on mute, just so we don't get any interference. And then when the time's right and people want to ask questions, they can unmute and switch their cameras off. Sorry, switch their cameras on, so we can see you. So with that, over to you, Julie.
Well, thank you very much, Garrett. It's a great pleasure to be here today and get a chance to talk a bit about one of the things that I'm really interested in, which is psychopathology and interviewing, how to best assessing that. So here is an outline of how my plan is to sort of develop the argument or discussing this. So we will start with looking a bit at what kind of thing is it that we want to examine when we do a psychiatric interview. And what is important to say here is that the kind of psychiatric interview I'm going to talk about today is the diagnostic interview that we would do with a patient in a more stable phase. I'm not talking about the sort of emergency room interview. Of course, that will not be what I'm talking about. But as we are going to discuss what kind of thing we are examining, I will have to talk about, or we'll get into the psyche, subjectivity, consciousness, and of course, symptoms and signs, typification, and also the gestalt. And after that, I will reach to talking about different kinds of interviews, and I will talk about the standardized structured interview and the semi-structured phenomenological interviews. And I will then at the end of the talk show you some empirical findings on the more sort of theoretical considerations that we have done on this. So the thing that we are trying to examine with the diagnostic psychiatric interview is, of course, the psyche or the lived experience of consciousness. And it is not just a set of behaviors or a brain state or symptoms that we want, or a set of symptoms that we want to examine. It is what we could also call the psychiatric, which is the psychiatric object, which of course consists of the symptoms and signs. But I will, I think I went a bit too far there. No, it is here. Yeah. So Carl Jaspers, he made an excellent description of the situation when examining the psyche. So I will just read that to you. If maybe I can, or maybe I can see it here. And he wrote, "We can grasp and investigate only what has become an object to us. Psychic life as such is not an object. It becomes an object to us through that which makes it perceptible in the world, the accompanying somatic phenomena, meaningful gestures, behavior, and actions. It is further manifested through communication in the form of speech. We either perceive it in these phenomena directly or at least deduce its existence from them. The psyche itself does not become an object. Psyche is not to be regarded as an object with given qualities, but as being in one's own world, the integration of an inner and an outer world. okay, so this is what we have that we need to examine. And then that would of course lead us to, yeah, well, what is the psyche then? And the psyche can also be translated to or called phenomenal consciousness or subjectivity. And consciousness is a temporal streaming that is organized into a field of consciousness. And consciousness has these certain structures, such as, for instance, intentionality, temporality, embodiment, self-awareness, and intersubjectivity. And all manifestations of the objects of our awareness occurs within our consciousness. And the phenomenal manifestation of thoughts and feelings and perception, that is a lived reality. And this is the really important point about this lived reality. And inner and outer is not sort of a strict divide what goes on inside and on the outside. It is because lived experience always includes both the inner and outer. So then what is the nature of symptoms and signs, and how are they best elicited and described? Well, as you know, symptoms refers to the patient's subjective experiences and signs to expressive phenomena. And the prevailing but implicit idea seems to be that psychiatric symptoms, they can be treated as something close to third-person data, that they are publicly accessible, and that they are entities independent of each other, and that they do not possess any kind of meaning, and they are suitable for context-independent definition and measurement. And this paradigm originates in somatic medicine, where it is actually very meaningful and adequate. Because here the symptoms and signs in somatic medicine, the symptoms and signs, they refer to an underlying physiological or anatomical etiology. Like jaundice, and that's the idea with the picture of the boy here, like jaundice points to the liver, or coughing points to the lung or maybe the heart. But that is not the case in psychiatry, because with a very few exceptions, we have no idea of the etiology of the psychiatric symptoms or the disorders. And the psychiatrist is not confronted with an arm or a leg, but with a whole person who is another situated and embodied consciousness. So what the patient manifests is usually not an isolated series of independent and referring symptoms or signs, but it is rather a certain whole. And the symptom is not a pre-given as an independent thing-like entity, but it becomes this and that or that symptoms through both its content, its structure, but also its meanings relations to other experiences. And the point with the arm, with the superficial cuts here, the picture I have here, is to say that this could be a sort of a psychiatric sign, but we have no idea what it means. Well, it means that something is wrong with this patient, this patient or this person is not well. Or maybe it's not even a symptom. Maybe this person has been gardening and have a very vicious rose bush or something like that. We don't know. So so if we look at the symptoms and signs, it's not just reports of things that happens inside the patient, like, for instance, a tumor which is inside the patient. That is not the case in psychiatry. But in somatic medicine, symptoms are often seen as a sort of subjective correlate of the disease, that could be pain or fatigue. But that is not in psychiatry. Here the symptoms are expressions of an altered subjectivity. And the symptoms do not exist in isolation. They are always contextual, relational, and meaningful. So what are the implications of this for the interviewer? Well, for instance, it is that the symptoms, they must be understood and not merely recorded. And they must be understood in relation to the patient's total experience and appearance. And when I say understanding here, I mean that we have to understand the patient's experience, not how I would experience it, or not some kind of explanation of why the patient is experiencing it. And of course, the symptoms must always be examined and understood in the context of the particular patient. And the psychiatrist or clinician is not registering data, but are participating in a process of understanding how the patient's consciousness is structured and how experiences unfold within this particular structure or this particular framework. So when we have also to look a little bit about this was more like the patient, but then we need to look at how the interviewer experiences or gain access to the patient's experiences. And here the concept of prototypes are very helpful for us, because the idea is that of a prototype is that it is a central exemplar of a kind of something. So that any given concept has a real world example of the best or this central example that best represents the concept. And some members of a category are more central than others, and that is the point with the bird here, because a sparrow is a better prototype of a bird than a penguin is. And prototypes is something that we learn throughout our lives. So, and it is a cognitive feature, it's a cognitive human feature that we use to categorize and navigate in the world. And for instance, so when a child has to learn what the prototype of a bus, the child is shown buses, maybe ride a bus, but it's also shown a truck, which is something that perhaps could resemble a bus, but not is a bus. So that's really important for learning these prototypes. And we use them, it is a cognitive feature that we use this for typification of our experiences. And this is also used when we assess psychopathology. We use pattern recognition and pattern completion when we make typifications of both symptoms, signs, and also of diagnostic categories. And the idea here is that I guess you can all see that these are boats, because you have pretty strong prototypes or know the central, what is important for something to be a boat. So even though the Vietnamese boat might look a bit different than the more modern yacht, it takes you a second to see that this is all boats. And with the last picture here, you use pattern completion to see it, because you actually only see a very small part of the boat, but you have no doubt that this is a boat. And this is sort of the idea that the patient also manifests these meaningful wholes that are interwoven, meaningful wholes of interwoven and interdependent feelings, ideas, expressions, and behavior. And all psychiatric typification begins with these meaningful wholes. So when we see the patient, we might only see a little part of the boat. We might not see everything, but we get these typifications, and then we all the time or constantly during the interview will have to test these typifications. Can it really be this kind of symptom or this kind of diagnosis? So, and our perception is of course also structured by our consciousness. And in our consciousness, perception is also understood as these meaningful wholes. It is not just a collection of stimuli. So when I experience something, my experience reflects my personal sense of coherence, intentionality, and embeddedness in the world. So we can say that seeing is always seeing as. So when I look at this picture, I immediately see an angry man. I do not infer from different aspects of his expression that he must be angry. I do not put together that his fist is clenched and his cheeks are red and his facial muscles are contracted and say, oh, this must be an angry man. I see it directly. So the understanding of the meaningful whole here is imbued in my perception. It is not superimposed on my perception. And I think that is really important because this happens no matter if we want it or not when we are in the interview situation with the patient. So we need to use it. Right. So the patients, they rarely manifest sort of isolated independent symptoms and signs, but it is rather what we see are aspects of these wholes. And that is also what is called gestalt. And these consist of these interdependent feelings and expressions and actions and beliefs. And here again, I have a quote from Carl Jaspers, who I think gave a very clear description of this. And he wrote, in grasping particulars, we make a mistake if we forget the comprehensive whole in which and through which they exist. The whole comes before its parts. The whole is not the sum of its parts, it is more than them. It is an independent and original sort. It is form. The whole cannot therefore be grasped from its elements alone. The whole must be seen through its parts and the parts from the aspects of the whole. So there is a back and forth movement when we are assessing patients. So from the parts to the whole and from the whole to the parts, because they only make sense when seen together and seen in this back and forth movement. So one can say that subjectivity is not hidden behind behavior, but it actually manifests in the gestalt. And before we turn to the different kind of interviews, I will just give a word of caution about these typification, because there is of course a risk of forming sort of private prototypes which are idiosyncratic and unshared notions of what counts as normal and what counts as pathological. And this will of course lead to the loss of validity if someone has these kind of private prototypes. So to avoid that, clinicians must be aware of their implicit typifications and cultivate them through supervision, dialogue, and formal training. Okay, with that said, let's turn to the interview. So how are we to examine the psychiatric object, the lived experience? Well, there are primarily two approaches to interviewing, and one is the structured interview and the other one is the semi-structured interview. We can of course also do a fully unstructured or freestyle interview, but I will not talk about this here because we do have some kind of structure because we want to examine psychopathology, so that gives some kind of structure no matter if we use one or the other. But the definition, when I talk about the structured interview, what I'm talking about is that it consists of a set of predetermined questions presented in a definite order. Diagnostic information is yielded based on the patient's responses and the clinician's observations. And an example could be the SCID, which is the structured clinical interview for DSM. And these interviews, the structured interviews, attempt to identify symptoms and syndromes which meet specific diagnostic criteria. So what is really important here is the predetermined questions and that they're presented in a definite order. So The alternative is a semi-structured interview, and it provides an opportunity for the interviewer to hear the patient talk about particular aspects of their life or experience. The questions function as triggers that encourage the patient to talk. Through his or her comments, the interviewer steers the interview to obtain the relevant data. The important thing here is how the interview is conducted. It's not so important how a given interview defines itself. For instance, the skit is definitely, looking at the user guide, it is definitely supposed to be used in a fully structured way, and also it is in the title, the S stands for structured. But of course, I can take the skit schedule and I can put it in my desk drawer, talk with the patient, and then fill in the skit afterwards. And then I'm using it in a semi-structured way, right? So it depends on how it is used, whether we would label it structured or semi-structured. Right. So the structured standardized interviews were created after the famous US-UK project, which in the beginning of the 70s demonstrated that there were an alarming low reliability of the psychiatric diagnosis. And this led to what has been termed the operational revolution, where the operational diagnostic criteria was created, with the first ones was the DSM-3, which was published in 1980. And it also led to the standardized structured interviews. And Robert Spitzer, who was an important figure behind both the creation of the DSM-3 and also behind the structured interviews, he argued in his famous paper with the polemic title, "Are Clinicians Still Necessary?" that the structured interviews could be done more reliable, or could be performed more reliable by naive raters than by clinicians. So his argument here was, with this new invention of the fully structured interviews, we would not need clinicians anymore. And of course, he didn't mean that. It was a sort of a polemic speech he gave, and then it was made into a paper. But here, one of the arguments was, of course, that with the naive raters, they would stick to the questions as they were written, because they wouldn't know what else to ask for. And they were very inexpensive. Whereas the clinicians, they would not stick with the questions, and they were expensive. So he thought this was really the way forward. Okay, so here I have tried to make an illustration of the idea behind the fully structured interview. Because some of the problems with why the reliability is low is because there is variance. There are several kinds of variance which occurs during an interview. First of all, there's the information variance, that is what the patient chooses to tell the interviewer. Then there is the criterion and interpretation variance, and that is how the interviewer understands the criterion, and also how the interviewer interprets what the patient says. Because what goes on here is that the patient is the one who has the experiences. So the patient has the information sort of in a first person data, and describe it to the interviewer, which then get it in what could be said some kind of second person level. And then the interviewer has to convert it to third person data, to reportable data. So that's why there are these three places where variance can occur. So in order to minimize the variance, the idea behind the fully structured interviews is that if you ask all patients the same questions, then the idea is that then the patient will say the same thing to the interviewer. And that is why the questions are pre-formulated. Usually the interviewer is allowed to ask for more information, but they have to pose the question as it is formulated, the first question, and then they can ask for more. And the next thing, to avoid criterion or minimize criterion and interpretation variance, the questions are formulated very close to the criterion that they are trying to reflect. Actually, it's usually the same. It's just a rephrasing of the criterion. So that means that the interviewer doesn't have really to interpret anything, because if the interviewer asks the patient the question that is already formulated, and it is formulated basically in the same way as the criterion, then if the patient says yes, then the criterion is fulfilled. That is sort of the idea. So this idea that you can examine consciousness in this way is rooted in a behavioristic paradigm, which was a very popular paradigm in the 1970s, where all this was created and the structured interviews were created. And it is very much or one thing about the behavioristic paradigm is that the brain is seen as a black box. So we can't know what goes on, not in any reliable way, know what goes on in the brain, but we can pose a stimuli and then we can see the response. So that is a bit like the candy machine here. So we can make a stimuli, so we put money in the machine, push the button, and if there's any candy on the shelf, it will fall out. That would sort of be the response. And as you can see, the candy is nicely ordered on each road for each kind of candy. But and so this again is this way of demonstrating that it seems that the implicit idea is that symptoms are taken to be objects in the world that can be assessed as discrete or atomistic or thing-like objects. And that they don't have any point in themselves, that they just point to sort of an underlying cause. So the question is, can we grasp the psyche with a structured interview? And obviously I don't think we can, because the structured interviews, they try to isolate symptoms from the flow of lived experience. And this often makes it difficult for the patient to recognize their experience in the questions, and also for the clinician to grasp the experiential structure of the patient. Another problem is that it is decided beforehand what counts as relevant information, because the patients are only asked about the question that are symptoms that are pre-formulated. And also in the fully structured interview, little attention is paid to context, and there is an exclusive focus on the content of the experience, neglecting the structure of the experience. And when I talk about the content, it could, for instance, be the content is that I believe that my tap water is poisoned. That would be sort of the content of my experience. But the structure is, how do I know that? How did I become aware of that? And how do I react to it? That's very important as well in trying to decide whether this is a delusion or not. And with these questions, sort of these pre-formulated questions that I ask, and then a simple yes will suffice. I can ask for more information, but I don't have to. It makes it very difficult to make typifications. And to give an example, the phenomenon of or symptom of social phobia is probably a very different symptom depending on the context where it arises. So if it is in a patient who has a suspicious attitude, it is probably a different phenomenon than in the melancholic patient who has self-reproach. And it can also be a patient who believes that others have access to one's thinking. So it's probably, so even though it's on the surface, is the same phenomena, avoiding other people, it is very different what's below it. So we need another kind of interview, one that is more adequate for catching or sort of assessing consciousness. And here the phenomenological interview is a good alternative, and it has to be a semi-structured interview. And I will start with describing a little bit of the phenomenological techniques that can be used in the interview. The first one is the epoché, which is suspending judgment to make the experiences open for examination, and also to staying with the patient's experience until it is understood. So trying to keep asking information about this and try to search together with the patient for information, more information about the experience. And in doing that, we would need another phenomenological technique, which is the eidetic variation, where we try to identify what are the essential structures of an experience and what are the incidental or trivial experiences. And we do that by varying different features of the experience to see which one are important and which are not so important. And to give a primitive example, I have this blue sphere. And the idea is that now the sphere is blue, but if we variate it so we make it red, will it still be a sphere? Yes, of course it will. Right, so okay, so the color of this sphere, that's trivial. We could also make it larger or smaller, but it will still be a sphere. So that's also a trivial aspect. But if we changes the distance from the center to the surface in one part of the sphere, then it will no longer be a sphere. So that is an essential feature of the sphere. So that is the thing that we need to examine when we see the patients and try to find the essential aspects of their experiences. And it is very much more difficult than for this sphere. Right. So the semi-structured phenomenological interview, it is of course guided by psychopathology, but it must be flexible, and it is focused on exploring these subjective experiences, and it must follow the patient's narrative and not present or asking questions in a definite order. It must follow the patient's narrative, and it must be based on phenomenological training of the interviewer and also comprehensive knowledge of psychopathology. And the point is to grasp form and structure of the patient's experiences, but of course content is also important, but we need both parts. And it must be seen as a joint search between the interviewer and the patient for this essence of the experiences. And taking a chronological social history is a good point of departure for such a psychopathological exploration, because it will provide an understanding of the patient and their context and the illness phases, and give a good idea of this. And then we have this staying with, as mentioned in the previous slide. So staying with the patient's experience, and that means resisting a premature interpretation or categorization, and allowing the experience to unfold on its own terms and structure. And that is a problem. That is also a problem with the pre-formulated questions, that it makes it very difficult or impossible to stay with the patient's experience. Right. So now I have tried to discuss or describe the kind of thing that we want to discuss, the consciousness of the psyche. And I have argued that the fully structured interview is not an adequate way of examining the psyche. And I have suggested that semi-structured phenomenological interview, it's a much more appropriate way of examining the patients. So let's have a look at some empirical studies on the subject. First, I will present one of my own studies, which is a bit old. But the aim here was to test the validity of a fully structured interview, and we used the SCID, the Structured Clinical Interview for DSM, as a representative for the fully structured interviews. And what we did was that we interviewed first admission patients, and all patients were interviewed and diagnosed twice. First, they were interviewed using the SCID, and that led by a novice rater, and that led to a diagnosis. Next, they were interviewed with a semi-structured phenomenological interview, and also it was me, I was also a psychiatrist at that time, and that also led to a diagnosis. And all diagnoses were DSM-4 diagnoses. And then we did a consensus best estimate diagnosis where we used all available information on the patients. Videos from all interviews were videotaped, so we used videos from both interviews. We looked into the patient's files where there would usually, because the patients were admitted, so they had treatment as usual and diagnostic assessments as usual. We could see that. And in the patient files, there would also be information from relatives. And based on this, we were several experienced psychiatrists who made the best possible diagnosis. And this is what we said, this is the best possible diagnosis we can make. So this will be the gold standard. And the sample was 100 first admission patients. They were included independently of whatever diagnosis was suspected, unless there were substance use disorder or if there were known cause brain disorder. And the 100 patients were 34 men and 66 women, and they had an average age of almost 28 years. And we imposed a hierarchy on the diagnostic groups. And this is the hierarchy we impose because it is DSM, so it doesn't have the same hierarchy as we do have in ICD-10. So if a patient had a diagnosis of schizophrenia, that diagnosis was the one we used. Then other non-affective psychosis, bipolar, and major depressive, and then schizotypal disorders, and then the rest of the diagnosis, personality disorder, OCD, diagnosis like that, was all pooled in the other group. And then we saw the agreement about the diagnosis from the diagnosis made from the SCID interview and the best consensus diagnosis. And the kappa was 0.18, which is a very low kappa. Kappa is a sort of a statistic measure who takes into account that by chance two measures will agree sometimes. So if a kappa is 0, then there is no agreement, then it's completely random. And if kappa is 1, then it's perfect agreement. So in this situation with 0.18, it is much closer to no agreement than to perfect agreement. And when we did this study, we of course did it because we thought that there was a problem, but that the problem was of this size was a bit of a shock to us. Right. So here I know it's a bit of an annoying slide, but the idea is that in this direction we have the best consensus diagnosis divided into the 6 groups, And in this direction, we have the SCID diagnosis also divided into the 6 groups. So you can see that from the 100 included patients, there were in total of 8 patients who were diagnosed with schizophrenia with the SCID diagnosis, with the SCID. And the same, wow, that circle is a wrong way. The same number for the best consensus is that 42 of the patients were diagnosed by the best consensus as having schizophrenia. So that's a large difference, a huge difference. And the other one I want to show you is that the SCID diagnosed 50% of the patients with major depression, and the corresponding number was 14 in the best consensus diagnosis. Right. So we also looked at the validity of the structured interview or the SCID. And we could see that if we compared diagnosing schizophrenia versus all other diagnoses, then the sensitivity of schizophrenia was 19%, but the specificity was high. And if we sort of enlarged the diagnostic category to be schizophrenia spectrum disorders, we could see that the sensitivity was 44%. That means that the SCID correctly identified 44% of the patients, that is less than half of the patients suffering from schizophrenia spectrum disorders. And if we looked only at schizophrenia, it was only 20% of the patients who actually suffered from schizophrenia who were diagnosed. Right. So no, it's not last year. It was in 23. There was made a replication study of the old study of mine in Norway, and this is completely unrelated to us. Of course, we knew that it was going on. They told us about it, but we were not involved in any way. And they did exactly the same study. They included 55 first admission patients, and the patients were included from a unit specialized in psychosis. So all patients must have been suspected for psychosis somehow. And they found the agreement, the kappa value in their study was 0.21. And if you remember that the study was 0.18 in my study, so it's almost the same, it's just as bad. So I think with this replication study, it's a pretty strong suggestion or support for the more theoretical idea that these interviews are not an adequate way of diagnosing. So I don't know what time is it. Do I still have time?
Yep, you do.
Yeah, all right.
You got a bit of time. We started a little late. All
right. I just wanted to give you an example of a patient who was asked about if he experienced thought insertion in the SCID interview. And here the interviewer asked the patient, have you ever experienced that certain thoughts that were not your own were put into your head? And the patient says, no. And then the interviewer asks, what about thoughts being taken out of your head? And the patient shakes his head to deny. So the patient did not recognize these experiences. Then I talked with the patient, and I'm afraid this is a bit longer. So in the interview I did with him, we also touched upon this thought insertion. And I asked the patient, does it ever become, before what goes before this section of the interview is that the patient has told me that he has so many thoughts in his head, and also that he has a feeling of some kind of special importance or something like that. He has told me about that. And the patient is 19-year-old. He's just about finishing high school. And I ask him, does it ever become too much with all these thoughts? And the patient says, sometimes. Sometimes I think that the thoughts take over somehow, so I cannot get rid of them. Then the thoughts run their own race. And I ask him, can you say a bit more about that? And he says, it's like the thoughts are out of my control. And then I ask him, can you get a feeling that the thoughts are somehow alien and not really your own thoughts? And he says, yes, sometimes it's like they are, when the thoughts are kind of solemn thoughts, or how to put it, then I can get the feeling that they have been sent from another place, from elsewhere, because if they are not mine and they are solemn thoughts, then they must be something special. And I ask him, do you have any idea from where they could have been sent? And the patient says, from God. Then I ask him, what are solemn thoughts? And he says, they are very different from my usual thoughts and thoughts that other people don't think. And then I say, and then you think that God is sending you these thoughts? And the patient says, yes. And what he continues to say, because I then ask him, well, do you really believe this? How much do you believe in this? And he says, well, sometimes I completely believe this. I'm absolutely sure this is it. And I have had that for months. And at other times, I'm not so sure about it. But overall, it does seem like this patient actually do experience thought insertion. And because he is having thoughts put into his head from the outside, from God. And you wouldn't think that thought insertion, that is sort of, you would think that you would recognize that experience, wouldn't you? And of course, I don't know why the patient doesn't recognize this experience when he's asked about it in the SCID interview, but I can have some ideas about it. And I think one of them is that that he might not recognize his experience in the way the question is phrased in the SCID. And I also think that maybe this experience only really articulates for him as we are talking about it here, that it becomes, of course he has had the experience, but I don't think it is so clear for him before that. Maybe it can of course also be that many patients, they tend to dissimulate, who want to appear crazy, and I think if you asked if your thoughts are put into your head from the outside, you would know this is now you say no if you don't want to appear crazy. So I think, and of course there can be other reasons as well, but I think that is at least some of my ideas of what is going on. All right, so my major conclusions here are that the fully structured interview conducted by a rater without substantial psychopathological knowledge is not an adequate way to assess psychopathology and to allocate diagnoses. And there is a need of a methodological approach that is faithful to the experiential reality, rather than an approach that implicitly distort reality to make it fit its own prejudices. So what do we have to do? Well, I think that we need to revive teaching and training in psychopathology, and also of comprehensive differential diagnosis, because the single most important factor for successful interviewing is knowledge of psychopathology. And if you have this knowledge, then you would never conduct a fully structured interview, because it simply doesn't make sense. And to revive teaching and training in psychopathology requires far more than training in a selected interview schedule, because that's not really psychopathological training. That is much more training in the technicalities of this particular interview. So what is needed is academic studies, supervised diagnostic interviews, joint interviews with colleagues, ongoing peer discussions of psychopathological concepts, and participation in consensus meeting with experts for differential diagnosis, diagnostic evaluations. And I will end with a quote from outside of psychiatry. This is a quote from Professor Kinsley, who in the 1940s conducted a large study on sexual behavior in humans. And he spent a lot of time thinking about how he were to get frank and full confessions of their sexual practices from these individuals, because it wouldn't make any sense to do the examinations if people were not honest. So he actually devoted a full chapter in his book on sexual behavior of the human male to diagnosing. And I have a quote from him saying, "The quality of a case history begins with the quality of the interviewing by which the data have been obtained. However satisfactory the standard deviation may be, no statistical treatment can put validity into generalizations which are based on data that were not reasonably accurate and complete to begin with." Thank you.
Well, thank you very much. Thank you very much, Julie. So it's great to get back to basics, or on matters psychopathological, and you've certainly helped us do that with your talk. So as people gather their thoughts or questions that they want to raise, I had one thing, just if I can start listening to you, which was really about how you see the role of the specialist and the generalist here, because I thought quite a compelling point you made is that the quality of psychopathological interviewing will be to do with how the interviewer is able to relate prototypes in a comprehensive way to what's being elicited at an interview. And of course, in academia, we're constantly encouraged to be specializing. So to be considering, everything in terms of special kinds or disease kinds. But the implication of your talk really was that it's going to be extremely important to be able to hold all different psychopathological kinds in mind in order to be able to elicit accurate clinical or psychopathological information. And because that's the holism that's required in the way you were talking about, eidetic or imaginative variation. I just wondered whether you had any thoughts about that, about how important it is to be a generalist in order to be a good psychopathologist, a good psychopathologist.
Yeah, but I completely agree with you. For psychopathology, you need to be a specialist in psychopathology. You can say that, but you can't be if you're a specialist in ADHD or in schizophrenia psychopathology, then you will run into trouble, because not so much as it is not that difficult if you are into schizophrenia, because you can see all symptoms in schizophrenia. But if you're a specialist in ADHD, then you will run into problems very fast if you don't know a lot about all other kinds of psychopathology, because problems with attention or difficulties with attention and motoric disturbances are symptoms that are not sort of unique to ADHD, that can be seen in many different diagnoses, in schizophrenia, in bipolar, in several other kinds. So you really need, because otherwise you would diagnose all individuals who have attentional issues and motoric issues with ADHD, but they might be psychotic, and that of course do not fit into the ADHD category. And also you would also need, when did this start? Did it start when you were 18? Then it's not ADHD, right? So you need a lot of you need to do a very comprehensive differential diagnosis. So you need to be a specialist in in psychopathology, but across all the different kind of diagnoses. And I think we have actually been discussing this quite a lot in our national psychiatric society, if we should try and make sort of a specialist education for psychiatrists in psychopathology. I think maybe we need it because, I think maybe we need it because it is the knowledge is disappearing because of a lot of issues, but maybe also because of this specialization. But some of my colleagues, they say, well, that's absurd because we all need to know the psychopathology. We cannot specialize in psychopathology. You can't, being a psychiatrist who is not specialized or do not know the psychopathology is like a surgeon not knowing their anatomy. So I definitely see your point, and I completely agree with it. But I think that psychopathology is so basic, and that is sort of the base for everything else, or for everything else that we do in psychiatry. So I think that's really important that we prioritize that, and I think it has been not prioritized for many years now.
Good. So other questions? Are we? I'm not keeping an eye on the chat, Po, but if anybody says put something in the chat, do let us know. But Quentin, I see you've got your hand raised.
Yeah. Thank you. Can you hear me? Okay.
You can.
Yeah. Thanks for the very interesting talk, and I find myself actually, like Gareth, agreeing with you in many respects, but I'm just interested. I mean, many questions arise from your talk actually, but one of the questions is, from one point of view, your talk could be taken to imply that in some way psychopathology and psychiatric diagnosis is a relatively settled body of knowledge with which one can become familiar and an expert in. And then with sufficient training and expertise, it can be applied to the individual case in order to establish an authoritative diagnosis out of a range of differential diagnoses. But I wonder the extent to which, how you, if that's a correct reading, if that's not an oversimplification of the sort of presuppositional background of your talk, how you would cope or manage or fit in diagnostic change, how diagnostic constructs can evolve. Mm-hmm. So, for example, in the case of autism and schizophrenia, after the initial description of autism in 1943 and then Asperger's syndrome and so on, there was actually about, up until really the early 70s, there was considerable debate amongst psychiatrists as to whether or not autism and schizophrenia should be separately conceptualized. And then there was some studies in the early 70s which seemed to imply that they should be separately conceptualized. And if anything, I think probably in recent years there's been an increasing recognition of overlap phenomenologically with some components of the features of autism and schizophrenia, and perhaps even at an etiological level with some overlapping genes, certainly not all genes, but some genes overlapping which conferred an increased risk, and possibly even some neurocognitive systems, etc., that may be implicated in both disorders. But the point about that is that, for example, I sometimes, because I'm a psychiatrist and I do a lot of work with people with autism, is that I'm sometimes asked to provide an expert opinion about whether a patient with psychosis has autism as well, or whether it needs to be understood in the context of that. And so a certain weight is attached to my pronouncements based upon my sort of clinical experience and role and so on. But it's a rather the way I think about it is that in actual fact think our constructs evolve. Our diagnostic constructs evolve, and our knowledge about conditions evolve. And it may be that certain symptom, if I can use the term symptom clusters, sort of, as you gave the very good example of the ADHD specialist, sort of, to a hammer, everything looks like a nail. So everybody's got ADHD if you see an ADHD specialist. But it seems to me that there's some kind of difficult balance that we have to strike in both retaining a sense of the validity and utility of the concept of diagnosis, whilst also recognizing its provisionality. And I wonder actually whether the answer to this might be in another component of your talk, which actually also goes back to Jasper's as well, which is actually something else which is going on in the diagnostic interview, something which Arthur Kleinman called empathic witnessing. So part of what you're doing actually is, whatever you're doing, you're always trying to establish a context within which it's possible for both you and the patient to find a language to articulate their difficulties, and also embed those difficulties with an overarching narrative which is culturally authoritative and intelligible at any point in history. So anyway, there's some reflections. I wonder what your thoughts are.
Well, thank you for that. Well, I very much agree with what you're saying, and I think that that could be a long discussion or a long talk about this, but there's no doubt that our diagnoses are constructs, and many of the psychiatric diagnoses, the validity is not that good. I think the most valid diagnoses that we have are bipolar and schizophrenia, right? But I think many of the others, the validity is difficult, and we can sort of cut the cake differently, and that is what is done with new diagnostic criteria, and we will have ICD-11 soon, hopefully, or maybe. So of course it is constructs, but I think I'm not sure I agree with you that we are gaining better knowledge on psychopathology. I actually don't think so. And precisely the example you're giving with autism is a thing that I'm very interested in the moment, because Bleuler was the one who coined the term autism in 1908 or 11. I can't remember which one it was the first time, but he was talking about schizophrenic autism. And then Kanner and Asperger took Bleuler's word in the 1940s. And I think that it is partly because of the knowledge of psychopathology that is sort of slipping out of our awareness, so that we have not known, because Kanner and Asperger both, if you read the original papers of Kanner and Asperger, they're very clear, these patients are not schizophrenic. And also the children, both in Kanner and Asperger, they are extremely autistic, right? They do not compare to many of the autistic children we see. Of course, some does, but we see many autistic children today which have a much higher level of functioning, right? But I think it sort of slipped out of awareness that autism was a part of schizophrenia and have always been described like that. So what we are sort of rediscovering now is, well, isn't these patients a bit autistic? And they are, of course they are, but I don't think that if we say sort of autism spectrum disorder, that would be Kanner, Asperger, developmental autism. That kind of autism is not the same as a schizophrenic autism. On the surface, with sort of social problems, social withdrawal, and having problem with social contact, it is the same. But beneath that, it is not the same. But I think that is because this original insight, or this old insight, it's not slipped out of awareness. Then we are rediscovering that, and now we are calling it that they have both schizophrenia and developmental autism, when I think in most cases it is probably only or just the schizophrenic autism that is at stake. But of course, you're absolutely right. And I don't about this being constructs and things can change also for the patients. So what you see at one point, we were talking about child and adolescent psychiatry just before we started. So we see patients who are diagnosed with autism and ADHD in child and adolescent psychiatry. Then we see them in adult psychiatry, and now they are psychotic. So now it's clear that this is schizophrenia. It is not that it was a wrong diagnosis that they made earlier. That was what was there at that time. So, but now the disorder has developed more, and now it's more clear. So then it's easier to see what was there. But of course, it is not like we know this for a fact. We don't have that luxury in diagnosing. So I completely agree with you. But I think that is why it is also so important that we have this constant and ongoing discussions about our concepts, both symptoms and signs, but and the diagnostic categories as well. Yeah, I don't know if that was any kind of answer.
No, thank you. That's very very interesting response. I can see there are a few others wanting to ask questions, so I'll allow them. But maybe I suspect we'll be running with the ball here, as we explore these issues. Thank you very much.
Good. So there's a few comments in the chat that we could pick up on, Julie. But I see Kate, you got your hand up. So do you want to come in?
Yeah, hi, sorry. Yeah, thank you for talking. It's been really interesting. And kind of, I feel like kind of gives me quite a lot of hope about kind of psychiatry not being so kind of rigid, I suppose. But I just wondered if you could say any more about what for you makes, because you've talked about construct and early ontification and the development of concepts. I'm coming from a lived experience perspective. I'm not a doctor. I'm doing semi-structured interviews, and in my research, and I noticed that you used Carla Willig to define a semi-structured interview. So kind of one of the things I'm thinking is, what would so I can do an interview that is semi-structured about someone's lived experience. What would you say makes a kind of a construct specifically psychopathological, as opposed, because I can ask about someone's lived experience, for example, if they're LGBTQ, and we nowadays wouldn't say that's medical. Obviously, in the past, that has been medicalized as a pathology. Also, I can interview people about their experiences of having an illness. But so the kind of core question is, what makes a construct pathological as opposed to not, is one of my questions. And a point, just to pick up, which is less of a question, but you said the most important thing for doing the diagnostic interview is knowledge of psychopathology. But I would also say, as a qualitative researcher, but also as someone with lived experience, that you have to have trust and you have to develop rapport to be able to have the kind of interview that you're talking about. So along with knowledge, there's the human that is as essential as the background understanding. So yeah, if you want to respond to any of that, please.
Yeah, thank you for that comment. Of course, you are absolutely right. That is essential. That you, but I may not have been clear enough, but that is also the understanding. That is sort of what empathy is, that it is the wish to understand the other person. And I think that's sort of key to everything. And I think that will transpire so much through that if you are really can sort of convey to the person or the patient that you're interviewing, I'm really interested in hearing your experience and what this has meant to you. I think that is, of course, really, really important. But without the psychopathological knowledge, it will be impossible to know what to do with the information in terms of diagnosing and using the diagnostic categories. in that terms, right? And this is the diagnostic interview I was talking about here today. And then you said, well, what makes something pathological? And that is a question that is very difficult to answer. But I guess it is what is when the experiences are deviating from the norm, and when it makes people suffer or their surroundings suffer. Because sometimes in psychiatry we have patients who actually do not themselves experience that they suffer from their pathology, but their surroundings do suffer from it. So I get, but I know that's a sort of a poor answer. I know it's very difficult to say precisely, but I think that is why it is really important to try and understand the framework of the patient that you're talking with, or the person you're talking with, whether to see if this framework has shifted somehow, and therefore the experiences have shifted. Because there are, of course, we can see a lot of experiences which, for instance, anti-waxers, right? When will we call that a delusion, and when will we call this is just what I believe in? So we have a lot of these cases, but I think what it really comes down to, it is if you can, when you talk with the patient, if their framework is shifted, and it is because of the shift in the framework that the experiences changes, then it becomes pathological. That's my best offer.
So, George, I see you've got a hand up. I'll come to you in a sec, but there are just a few interesting things in the comments. So Christos is making interesting references to outside of psychiatry, actually, to William Osler and Hippocrates, to kind of link in with this point about holism as important in differential diagnosis. But then there's also a question that's interesting from Afonso, and I thought we could link this maybe to some of the points that you made, Julie, in your presentation about how semi-structured phenomenologically informed interviewing can help reveal forms of psychopathological experience or self-disorders which are getting missed by the structured interviews. But what about the other way? So in situations where somebody may feel very convinced that forms of experiences that they're having are abnormal, in which the good interview will help to clarify that they're less abnormal than they may appear to somebody, or they're less belonging to a kind of category that's that the person in some respects is after or seeking. And of course, we're seeing a lot of that right now with ADHD and people seeking actively that diagnosis. So really, just a question about how good psychointerviewing can go the other way as well, rather than any things you want to respond to there?
No. It is with the ADHD, it really is a problem. I think there is, at least what we see in Denmark, is that yes, people are really seeking out ADHD diagnosis. It is a kind of a strange situation for us psychiatrists to suddenly have patients really wanting a diagnosis from us and getting angry if they don't get it. That at least for me, it's a new situation. But I think some of the patients that I see who really who thinks themselves that they have ADHD, some of them are very sick, suffer maybe from psychosis, and some of them I'm not sure that they are sick at all, and some of them have probably ADHD. I think it's very difficult because this spectra is so large. So I think it is, but I still think that doing a comprehensive examination of the patient or the person in front of you, trying to assess the structure of their consciousness, I think that is very helpful, because in ADHD, the structure should be normal. The symptoms of ADHD are very close to normal, so or they are structured in a normal way, but of course there still are these few problems, or few. I'm comparing with schizophrenia. That's why it becomes few problems, because for a person who suffers from ADHD, it will not be a few problems. But the structure is much more along the lines of the normal structure than it is, for instance, in schizophrenia, where the structure has shifted. And I don't think I can say any more about it. I think there are some huge issues with the ADHD. I'm an adult psychiatrist, so I see adult patients. And there's a huge problem with the diagnosis of ADHD in adults if it has not been made when they were children. Because the problem is that the criterions, the diagnostic criteria are, most of them are signs. So they are sort of expressive features, but they have been undergone some kind of subjectivization. So now the patient come and say, well, I can't concentrate. But that is not what we see when we see it in children. Then we see the teacher saying, or the parents saying, this kid cannot focus. And is that actually the same? And I think most people do feel from time to time that they have problems concentrating. So how much problems should you have concentrating before it's sufficient for a diagnostic criterion in ADHD? I think it's completely unclear. And the diagnostic criteria was developed on children. So I think it's a huge problem. I think we need much more knowledge about this, and we need research on the psychopathology on adult ADHD, or the subjective side of ADHD.
And whether psychopathological interviewing is helpful there, because rather than having some idea of a cutoff on a level of severity of symptoms which are on a continuity with normal life.
But the problem with the interviewing is that what we are after in the interviewing are the things, especially the things that we can't see from the outside. And we simply don't know very much about the subjective pathology of ADHD. So of course, to do a comprehensive differential diagnosis, it is always very helpful to do a good interview. But to conclude whether this is a patient who has ADHD and nothing else, I think that's very difficult. But I think that's in general, that's not, there's a problem with the diagnostic criteria. I think the validity is very, very low in adults. Not in children, I don't know, but in adults. Because now we don't have the other person, the outside person, saying that there is something wrong with this child, or this child behaves differently than the other children. We don't have that.
You mean that we don't have the school report or the?
Yeah, because
the parent
it
report
is very different from other people saying, when you are a teacher and you have 30 kids in the class, and one of the children is behaving or having so much more problems focusing than all the other children, then you're sort of calibrated. But if I just come and say, I have problems concentrating, what does that mean? And how much concentrating? Because everybody has problem concentrating. If I suffer from schizophrenia, I have problem concentrating. If I don't suffer from any mental disorder, I have problems concentrating. If I suffer from ADHD, I probably also have it. So I don't know. But I think that's an ADHD problem. We just published a paper on on how ADHD is diagnosed in adults in RCT studies, and it is a complete mess. It's really a big mess. I think it was more than 50%. We only looked in RCT, which is sort of should be good diagnosed. The diagnosis should be made good there because they often have consequences for guidelines, right, when you do RCTs. And more than 50% of the studies did not make any kind of differential diagnosis. And that's extremely important to do a good interview. When you make a diagnosis, it always implies that you say what it is not. When you say it is this, that means that it is not this and this and this. And you can't say that if you haven't examined for it.
Yeah. George, let's bring you in. And Christos, I see you've got your hand up.
Right. Thank you very much.
George,
I very much appreciated your discussion of phenomenology and the phenomenological interview. But I just wanted to suggest, well, firstly, I also have always said to students that if you had to read one textbook in psychiatry, it would be General Psychopathology by Jaspers. I think a lot of people would probably agree with that. But I think that one can take the argument a bit further if one considers the work of Donald Davidson, the American philosopher. I don't know if you know about his work. He wrote about the radically different speaker. So you're confronted with a person and you know nothing about their cultural background, nothing about the way in which people think, the kind of beliefs, values, and so on that they have. How would you go about trying to understand or interpret what the person is saying? And it struck me that the radically different speaker could be the person with a apparent psychiatric disorder who's saying something that seems absolutely strange and difficult to believe that this person is not in some way has some kind of impairment of their psychological function. And he says, okay, well, what kind of assumptions do we make when we try to interpret what another person is saying that seems strange and bizarre on the surface? And he says, well, you know, one's looking for two characteristics. One is that you're assuming that what the person is saying is by and large coherent, so that their beliefs are coherent with their actions and their intentions and their emotional reactions and so on. And secondly, that what they're saying is going to be by and large correspond with the reality of the world, you know, that what they're saying is kind of, yes, it fits with most people's appreciation of the real world. And so he calls this correspondence, which is the appreciation of that it's something to do with reality, and coherence. And so his argument then is that one makes these assumptions, which he calls the principle of charity, right? So you start off, and it seems to me absolutely, when I came across this, I thought, gosh, seems so relevant to dealing with a person who's expressing strange ideas. And so he argues, and I think this fits very well with Jaspers, about what is pathological. So I wasn't convinced by your example of thought insertion. I wanted to know a lot more about that person. I wanted to know what was his system of beliefs, values, commitments, personal life projects, aspirations, you know, and what kind of religious background did he come from? You know, a lot of people hear God speaking to them. What does he? How does he hear it? In what sense? You know, what is the context? And this is where Davidson would say we need to know a lot about the person's holistic system of beliefs, values, and so on, and that generally we share the common psychological structures, so that we see, you know, across cultures, a connection between a belief and an action and an intention. And that principle of charity is, yes, I'm going to assume that this person has those things. And, so I think that your example of the thought insertion leaves me with some doubts. It may be right, but I really need to know a lot more about, it's very interesting because most people, when they talk about thought insertion, it's sort of more kind of banal and more obviously unlikely to be coherent. But, God, it's like somebody with extremist political views, whether they have a mental disorder. Indeed, does Donald Trump, and I know I'll never be able to enter the United States without being stopped, and now as I'm speaking in an unsympathetic way to Donald Trump, when he says that the 2020 election was stolen, does he really believe it? Or is he using this as some way of gaining support and playing on people's grievances and so on? And it's extraordinarily difficult, I imagine, even if one were to interview him for an hour, to actually determine whether this is a delusional belief or whether it's something that, it's a coherent belief in the context of what he's trying to do, that is to become a dictator and to create an authoritarian state in the United States. So I think I would suggest that Donald Davidson does take the argument further and does take the kind of concept of what is a good interview and what that such an interview should cover. I think he takes it a step further than what you've proposed, I think. I think it's worth thinking about him. The other thing that he argues, and this is perhaps illustrated in the Trump example, is that there's always perhaps an element of indeterminacy. Perhaps I just haven't investigated, I just haven't really understood enough about this person, that it may be that the person may say a couple of things now that may make me think, well, gosh, no, this is coherent. Oh, he's a Jehovah's Witness. That's why he's refusing. That's why he's refusing a blood. Oh, right. And that is coherent. And, So I'm just, so I agree with what you've said, but I think, one might be able to take it further. This arises for me, I'm interested in decision-making capacity. And when a person refuses treatment, when should it be respected? And if the person's refusal of treatment, I would argue, is coherent with the person's belief base and so on, even if it seems to be a not prudent decision to reject treatment, then I would argue it should be respected, because it is the person's authentic will, as it were, that person is expressing. So just a suggestion.
Yeah, that's an extremely interesting area, and I definitely have to look this Donaldson up. And I'm happy that you were not satisfied with my example, because of course it is completely context dripping. Of course it is, because I can't tell you everything about the patient here, but I talked with him for many hours. He definitely did have thought insertion, but he had a lot of other psychotic symptoms as well, but it was not clear from the SCID interview. He got a diagnosis of major depression in the SCID interview, and he got a diagnosis of schizophrenia in the best consensus diagnosis, and he was seen at follow-up 5 years later, still very sick from schizophrenia and not doing.
Oh yes, no, I accept.
But I'm happy that you're not.
I sort of assumed that there was more of the backstory about this. It's just that it's useful to bear this in mind. The principle of charity, to approach patients with the principle of charity, I think is rather critical.
That's really interesting. I will look that up. Thank you.
But George, and Julie, just to elaborate that a bit more, does that then mean that the education of the psychopathologist has to include exposure to very wide ranges of normality, so that you in order to be able to exercise the principle of charity well, you you're going to need to be able to be familiar with all sorts of extraordinary beliefs that people can have, or experiences that people can describe, which are not psychopathological.
Mm-hmm. Yeah, I think that would, it wouldn't be doable to know everything that, or be exposed to everything that people might think, but it's definitely very important to know a lot about normality, definitely, because otherwise you can't sort of draw the line, because there's usually not a sharp line, and I think that was the person who asked the question earlier on, but on what is pathological. There's often not a sharp line between normality and pathology in psychiatry, right? So you definitely need to be very aware of that. But I think again, so I think you need to know a lot about the normal structure and the normal beliefs. But I think what is really important here is that one thing is the content of the thought, the other thing is the structure. And if you have the content is never enough. Never is, of course, but rarely enough. You need the structure as well. But what we do when we have in our psychiatric units, if we have a patient who tells us, I'm being followed by the FBI or been spied on by the FBI, well, it's not impossible that that is happening, but usually it is not necessary for us to go and check and find out, is this really happening? Because the whole context of the situation, the way the patient is structured and all the other symptoms and signs will tell us, well, this is a delusion or this is not a delusion. So I think that's very important also here to get the structure and the context. And I think that was the point as well with the principle of charity.
Yeah.
Yeah. Well,
so the other thing that I think is important is to speak to people who know the person well, who are very helpful in then allowing you to understand what is the system of beliefs and values this person has.
Definitely, and it can also, we see it also a lot when it's religious. Then it's very difficult for us to, because if it's a religion, we come from a Christian culture, we're familiar with that. But then if we have a person from another religious group, and then we need to go to the preachers or something like that from that religion to get information about it, because we can't conclude anything about that. Yeah.
Gareth,
well, Julie,
question in the message.
Oh, am I missing something, Poe? Is there...
By John. I think it's quite relevant. It's about the schizophrenia construct.
Right, yes. So this is in the chat. Schizophrenia, I'll just read it out. Schizophrenia constructed an example of psychopathological validity is a bit surprising to hear. As we know, given its validity is usually questioned due to its inherent heterogeneity, lack of clearly defined core aspect, and the stigma assumptions, overlap with other conditions, and of course, lack of consistent biological markers. Given all that, how can we say it's a more valid construct? So some skepticism, Julie, about your claim that schizophrenia is one of our most valid psychopathological diagnoses.
Yeah, the reason why I'm saying it is that we have had descriptions of conditions that resemble schizophrenia and also bipolar disorder in all times, in all maybe not in all cultures, that in many cultures, the descriptions of illnesses that are very similar to that. So that's why it seems to be there rather consistently. And I think I don't think because we don't have any, there are more than 100 genes who has something to do with schizophrenia. I think because we don't know anything about the etiology, we can't say that it is not a valid diagnosis. I don't understand that point.
Yeah. So schizophrenia for you its validity is primarily based in its phenomenological structure and its continuity over time.
Cultures and times.
Yeah.
Thousands of years. Yeah.
Okay. Well, look, I think this is a good place to bring us to a close. Thank you so much for joining us from Copenhagen in Denmark. It's been an extremely interesting discussion, and thank you for getting us back to basics in the way you've done today, Julie. So thank you very virtual much. Round of applause.
Thank you. Bye.
Thank you.